Atrial septal defect or ASD is one of the most common congenital heart diseases encountered in adulthood. While frequently asymptomatic during childhood, its long-term hemodynamic consequences demand precise anatomical and clinical differentiation. Atrial septal defects are classified based on their embryological mechanisms and anatomical locations within the interatrial septum. Ostium secundum is the most prevalent, 70 to 80%. It is in the fossa ovalis region, caused by excessive resorption of the septum primum or inadequate growth of the septum secundum. It's the most common type, amenable to percutaneous device closure if adequate tissue rims 5 mm or more exist. Ostium primum about 15% in the lower portion of the septum adjacent to the atrioventricular walls and due to failure of the septum primum to fuse with the endocardial cushions, often associated with a cleft mitral valve or broader atrioventricular septal defects, requires surgical repair. Sinus venosus ASD about 5 to 10%, superior variety near the superior vena cava entrance and is more common, inferior variety near the inferior vena cava entrance. Strongly associated with partial anomalous pulmonary venous return, where right pulmonary veins drain into superior vena cava or right atrium. Coronary sinus variety less than 1%, located at the roof of the coronary sinus, caused by the unroofing or fenestration of the tissue separating the coronary sinus from the left atrium. Rare, causes a left to right shunt via the coronary sinus ostium. The physiological consequence of an ASD is primarily driven by a left to right shunt determined by the size of the defect and the relative compliance of the ventricles. Because the right ventricle is more compliant than the left ventricle, blood preferentially flows from the left atrium to the right atrium throughout the cardiac cycle. There is increased right atrial volume and right ventricular volume overload, right ventricular dilatation and paradoxical septal motion, flattening of interventricular septum during diastole, and there is increased pulmonary blood flow QP relative to the systemic blood flow QS. The severity of